Most people are told that high blood pressure is simply a problem of the heart. In clinical practice, that explanation is incomplete and sometimes dangerously misleading. Blood pressure is not controlled by the heart alone. It is regulated to a significant degree by the kidneys, organs that work continuously, silently, and with extraordinary precision to maintain balance inside the body. When that balance is disrupted, the consequences often unfold quietly, without pain, without early warning, and without obvious symptoms until the damage is already advanced. To understand this relationship, it is important to first appreciate what the kidneys actually do. They are not just passive filters removing waste from the bloodstream. Each day, the kidneys process roughly 180 liters of fluid, carefully reabsorbing what the body needs and excreting what it does not. In doing so, they regulate sodium levels, fluid volume, electrolyte balance, and, critically, blood pressure. One of the most powerful mechanisms involved in this regulation is the renin-angiotensin-aldosterone system, a hormonal cascade that determines whether blood vessels constrict or relax and whether the body retains or excretes sodium and water. When the kidneys sense reduced blood flow, they release renin, initiating a chain reaction that increases blood pressure in order to maintain adequate circulation. This system is essential for survival, but when it becomes overactive or dysregulated, it contributes to sustained hypertension and long-term vascular damage. The central role of the kidneys in blood pressure control is not merely theoretical. It has been demonstrated in clinical and experimental settings, including transplantation studies showing that blood pressure can essentially follow the kidney. When a kidney from a hypertensive individual is transplanted into someone with normal blood pressure, the recipient may develop hypertension. Conversely, transplanting a healthy kidney into a hypertensive individual can improve or normalize blood pressure levels. These findings strongly support the concept that the kidney is not only a target of high blood pressure, but, in many cases, a driving force behind it. Life 2024 MDPI. At the same time, the relationship works in the opposite direction. Chronic high blood pressure damages the kidneys progressively. Within each kidney are millions of microscopic filtering units, known as nephrons, each containing delicate networks of small blood vessels. Elevated blood pressure places continuous stress on these vessels, causing their walls to thicken, their internal diameter to narrow, and their ability to deliver oxygen and nutrients to decline. Over time, this leads to scarring, a process known as glomerulosclerosis, and a gradual loss of filtering capacity. Clinical evidence has shown that even modest increases in blood pressure are associated with a higher risk of developing chronic kidney disease, with studies indicating that each 10 millimeters of mercury rise in systolic pressure significantly increases that risk. Journal of the American Society of Nephrology, 2012, PMC 3206001. This creates a self-perpetuating cycle that is both clinically significant and often underappreciated. High blood pressure damages the kidneys, and damaged kidneys, in turn, raise blood pressure further. As kidney function declines, the body becomes less efficient at excreting sodium and water, leading to fluid retention and increased blood volume. This alone elevates blood pressure, But additional mechanisms are also involved. The kidneys may continue to activate hormonal pathways like the renin-angiotensin-aldosterone system inappropriately, sustaining vasoconstriction and preventing blood pressure from returning to normal levels. Research has also demonstrated a direct relationship between reduced renal blood flow and increased blood pressure, reinforcing the physiological link between kidney function and vascular regulation. Hypertension research, PubMed ID 7707157. One of the most dangerous aspects of this entire process is how little it is felt. Both hypertension and early kidney disease are often completely asymptomatic. A person may feel entirely normal, energetic, functional, and without any discomfort, while significant damage is already occurring internally. This is why these conditions are frequently described as silent killers. By the time symptoms appear, such as swelling in the legs, fatigue, changes in urination, or the presence of protein in the urine, the disease process is often well advanced. These signs are not early warnings. They are late manifestations of ongoing pathology. From a clinical standpoint, measurable indicators become essential. Blood pressure readings, kidney function tests such as serum creatinine and estimated glomerular filtration rate, (eGFR), when on urine analysis for protein or albumin, provide objective data about what is happening beneath the surface. An eGFR below 60 milliliters per minute per 1.73 square meters is generally used to define chronic kidney disease, and the rate at which this value declines is closely linked to blood pressure control. Evidence consistently shows that maintaining lower blood pressure slows the progression of kidney damage and reduces the risk of complications. New England Journal of Medicine, 2020, PubMed ID 33093616. Certain populations are at higher risk of this cycle accelerating. Individuals with diabetes, long-standing hypertension, advanced age, or a family history of kidney disease are particularly vulnerable. In fact, diabetes remains one of the leading causes of chronic kidney disease worldwide, often interacting with hypertension to accelerate vascular and renal damage. Journal of the American Society of Nephrology, 2012, PMC 32-06001. In these individuals, careful monitoring and early intervention are especially critical. From a preventive and therapeutic perspective, the most effective strategy is to control blood pressure consistently and proactively. This may involve lifestyle modifications, such as reducing dietary sodium intake, maintaining adequate hydration, engaging in regular physical activity, and avoiding substances that can strain the kidneys. In many cases, medication is also necessary. Drugs such as ACE inhibitors and angiotensin receptor blockers not only lower blood pressure, but also provide specific protective effects on the kidneys by reducing pressure within the glomeruli and slowing structural damage. Despite these available interventions, a fundamental challenge remains. Kidney damage is often irreversible once it reaches an advanced stage. Unlike some tissues in the body, the kidneys have limited capacity for regeneration. This makes early detection and prevention not just beneficial, but essential. Waiting for symptoms is a mistake because the absence of symptoms does not indicate the absence of disease. Ultimately, the relationship between the kidneys and blood pressure is not a simple cause and effect scenario. It is a dynamic, interdependent system in which each influences the other continuously. When functioning properly, this relationship maintains stability and health. When disrupted, it can lead to a gradual but relentless progression toward chronic disease, cardiovascular complications, and, in severe cases, kidney failure requiring dialysis or transplantation. Understanding this connection changes how we think about health. It shifts the focus from reacting to symptoms to monitoring systems, from treating isolated conditions to managing interconnected processes. Blood pressure is not just a number, and the kidneys are not just filters. Together, they represent a critical axis of human physiology, one that must be respected, monitored, and protected if long-term health is to be preserved. If this gave you a new understanding of your body, subscribe, because your health decisions today will determine your future.